This is one eventful video which we'll be sharing today, and this is the patient who was a female patient and had a significant cataract and was planned for surgery. And this is the fundus photograph, and I have skipped the portion where the capsular access was being done, and I'm operating this patient using my non-dominant hand because the steep axis orientation was such for this left eye that I had to make an incision in this meridian so as to reduce the pre-existing astigmatism. And as we can see that there is a significant nuclear sclerosis, and we are going for a direct horizontal chop, and chop has been created, and we can see the nucleus has been bisected into two, which is such a satisfying event when you are doing such cataracts, because one single chop which is successful is key to the further eventless surgery. However, things can go wrong at any point, and this is the delicateness and the fineness of the surgery of phacoemulsification, where things can simply go from absolutely normal proceedings to some amount of complication, and that is why this surgery has a significantly steep learning curve. The nucleus is being chopped into smaller and smaller pieces, and this is important because this will facilitate the removal of the nucleus without interfering with the corneal tissue, because I believe that larger chunks, they tend to prolapse into the anterior chamber and may rub over the endothelium, which I find is the most important tissue which can cause post-operative corneal edema and keratitis. However, we have chopped the half of the nucleus into smaller pieces, and we are proceeding to emulsify them and remove them from the cavity. I usually use my right hand if possible, but in given situations where it can benefit the patient, I usually can switch to my left hand, and I have to take some special extra care, and I have found that it is possible to do it with the left hand, but at times it becomes little more time consuming and I have to strain myself more than what I can do with my right hand. The nucleus has been removed, and it is now the turn of epinucleus to be removed, and as we can see, the subincisional portion of the epinucleus is still retained, and I am adamant to remove this using my phaco handpiece and the tip. So I am manipulating the handpiece such that if it can reach up to the epinucleus, which is nearly subincisional area now. This was little extra effort from my part, but however, I could see that I have been able to remove this epinucleus with some success. And at this moment we find that everything is fine, and note what happens next. The moment I pull out the phaco tip, the anterior chamber collapses and the PC stretches, and there is a posterior capsular rupture. Let's see that in a slow motion, and we will find that we can see that happening in front of our eyes, and we can see the rupture being created from one end to the other end, and viscoelastic is being injected so as to normalize the anterior chamber configuration and pressure. However, the damage has been done. So this is one situation where you can have a posterior capsular rupture just because the chamber collapsed and the PC stretched towards the cornea and was damaged. However, in this situation I can also see that there is no vitreous disturbance, so I could proceed with my cortical aspiration, thinking that I should be able to remove this cortex successfully without disturbing vitreous, avoiding the area where the posterior capsular tear is there so that the vitreous doesn't get hydrated and there is no prolapse of the vitreous. So in a nutshell, one should keep the anterior chamber inflated and should not take chances like this. And I would even suggest that when you exit out and if you find that the anterior chamber may leak, we can use a swab stick just to occlude the lips so that the anterior chamber is maintained. However, in this given situation, the vitreous has behaved pretty well. Until now, the vitreous has not yet prolapsed into the anterior chamber, and that is something which is very consoling and makes the surgery less eventful and less complications are there. Trying to remove the exactly subincisional area, which in spite of being engaged is not coming out easily, and this is a situation where one has to take conscious decisions so as not to increase the amount of damage, and at the same time also finish the surgery so that it is picture perfect. At this point, I had thought of giving up that portion so that can be extracted later on and inflating the anterior chamber with viscoelastic and moving on to enlarging the side port so as to accommodate my Simcoe cannula, which can be used if the wound is designed in such a fashion that it tightly fits the incision. It will behave just like your phaco handpiece and IA tip. So you enlarge the incision just a little bit so as to tightly fit the IA Simcoe cannula, and then one can have a closed chamber situation and remove this chunk of cortex which is hiding underneath the main incision. Here we can again see the PC rupture, and because there is no vitreous prolapse, we are planning to implant the intraocular lens, but I can see that the rupture on the PC is from one clock hour to the other. It is diagonally set, so it is better not to implant the IOL in the bag. It will definitely sink down later on rather than placing the IOL in the sulcus. Now it may be a controversial point that why a single piece IOL is being implanted into the sulcus, but that is something which we can discuss some other day. However, I have found that these IOLs are tolerated well in the eye and they are centered well. Now there is one more complication which I can see is happening, and that is the leading haptic has got twisted because of improper orientation in the cartridge, and I can see that it is causing the IOL to twist to one side. Now this is one added complication which I was not anticipating. However, we will see what can be done. So first of all, taking care to place the trailing haptic into the sulcus so that at least we have some anchorage of the IOL, and then reaching around to rotate this haptic which has twisted upside down, and this will need some more manipulation. I can see that one dialer itself cannot take care of the situation because the IOL must have been twisted and bent to the other side. So what we will need is pull out this IOL from the sulcus, this haptic from the sulcus, and then push it back in correct orientation. And this is the procedure how it can be done. Though this portion reveals that how badly the IOL is twisted, and this is all because of improper loading where the haptic was not folded, rather it was extended in the cartridge, and when it came out in this orientation. Because vitreous is not yet disturbed, so we can still see the IOL is well centered. It is not being pushed to any side by the vitreous strands, and we can now proceed on to remove the viscoelastic gel. Removing the viscoelastic gel is an important job because one should be very conscious that if the viscoelastic gel is left behind, it will definitely cause a post-op intraocular pressure rise. This was sweeping the fornices in the anterior chamber so as to remove any strand of vitreous which you couldn't find. This is the day 1 post-op picture, and we can see the cornea has some keratitis, but patient had good vision, that is 6/18 BCVA. Thank you.